Bryn, could you see the questions that have been posted for the panel?
I can. Yes,
All
thank you
right.
so much.
We'll
This is a
go
great
ahead. Yeah.
Okay, great. This is a great one for you, Dr. Ackerman, and I'm actually very interested in your response. Why is the dosage for beta blockers based off of weight rather than the severity of our long QT?
Well, the short answer is it's not based off of weight. It's based off of everything. So I think we for a long time have been doing personalized therapy in patients with long QT syndrome long before it got called precision medicine and individualized medicine. So long QT specialists like Arthur and I, we size up the threat, the perceived risk of the LQTS substrate. We size up their responsivity to a beta blocker dose in terms of generating a measurable circulating level of beta blocker in the system. And we size up our satisfaction with our patient and how they're satisfied with the beta blocker dose. So, we aim to achieve what I call the MTD, the maximum tolerated dose, that doesn't tip the balance from a low risk substrate to a new problem called I hate life every day on beta blockers. So I think anybody who says we just dose the Nadolol and propranolol based upon your weight X milligrams per kilogram is way off the mark as to how we actually do it. We have a target. We generally think of Nadolol as wanting to have it be 1 milligram per kilogram per day territory. We have a target for propranolol that we want it to be in the 3 to 4 milligram per kilogram per day territory. But we have some patients who are dosed well below that weight-based target. And we have other patients who are dosed well above it. So it's that weight per kilogram or milligram per kilogram is simply a target that we have as a reference point. By the way, Jennifer, Dr. White, it's great to have you on. I loved your talk. Wish you could have given it live, but that was a wonderful 10-point tips to live by. So, and great to see you, Jennifer.
Good to see you too. Thank you. Sorry, I'm literally running from a shift, so I appreciate the patience. Good to see everyone.
Great. The next question I think would be great, Brittney, if you could answer this. Also another insightful question. How would you recommend approaching the positive genetic discussion with disconnected family members?
Yeah, so with disconnected family members, it can be difficult. And I think it depends on what your level of connection with them is. If you're disconnected just because you don't talk to them much versus it's disconnected because there's been some sort of like break in the family, like there's a specific reason other than just you're not close. Those are both handled a little bit of a different ways. For those that you just aren't in touch with much, social media is really great. I think even if you aren't in touch with a lot of these relatives, you might be on social media, or for those that may not be on social media, sharing things like family letters and kind of blanket information with links or websites with more information, or calling a professional rather than, so you don't have to feel like you have to explain it yourself. For example, my family letters always have my email and phone number in them, and so I talk to family members who aren't my patients all the time, just because it's difficult to put that burden on the family member for them to try to explain these difficult concepts. And sometimes that can make it a little bit more real. When there's been breaks in the family for tension reasons or kind of discord reasons, I have, with family permission, in some cases, I put myself as the middleman in those situations of, with that person's permission, I will reach out as a neutral third party rather than them getting involved. So it a little bit depends on the reason behind it. That's often a large part of our discussion around it.
Thank you so much. Jennifer, I have a great question for you. Should long QT be disclosed to an employer or even just an office staff member who's always there for safety? And should I push to ensure an AED is on site?
That's a great question. I struggled with that one myself. I'm sure you heard some of my story of everyone on the panel, but what I told people in the emergency department after I got my ICD was that I'm the safest person here, so no one has to worry about me. I did want to know where the magnet was. I think that you can disclose whatever you want to disclose. I think a lot of people don't understand what this is. Again, along the lines of not becoming a professional patient, try not to let this define you. It really shouldn't. It shouldn't get in the way of anything you do. So if you're well treated, and particularly if you have an ICD, to be honest, I think that you're very safe and you can keep that secret to yourself. If you want to tell a buddy or somebody that, needs to know, if you have a medical alert bracelet, if you have it in your emergency contacts in your phone, I think that's probably enough. It's your life. It's your information. If you want to tell people because it either comes up or you're in a situation where you feel like you might be unsafe or you don't feel like you want to do something. So, maybe if someone suggested at work that you spot someone on a high ladder or something and your beta blocker dose went up recently and you feel like you might not be able to be safe to do that, then I think that's fair. But at the end of the day, I think number one, you absolutely do not need to disclose anything to anyone that you don't want to tell. If you want to tell people, that's fine. And then it depends on what kind of job you have and what kind of risks are associated with that job. And then being as protected and as well cared for as you can, then you live your life. I think it's no different than perhaps if you were anaphylactic to bees, right? And then the bee got in the room and all of a sudden, this became an issue because the rare event of something happening to any of us is so rare that it's way more common for a common thing to happen to any of us. And those things you can never predict.
So Bryn, I would just jump in and add to that the one qualifier would be, I agree with that, except if we're talking about an athlete, as I discussed. So that would violate one of my mandates that an athlete and his family can't stay an athlete in a covert operation where they're not disclosing to the appropriate coaches and the team officials and the referees so that they've deprived them of a safety plan. Those covert operations, they have never turned out well. And so I think the difference, just for make sure that people are watching, there's a difference between what I advised earlier with the athlete and what Dr. White's advising with whether she as an employee needs to tell an employer about her health status.
Great discussion. Dr. Wilde, my daughter was diagnosed with long QT1 and through genetic testing, my mom and I carry the gene. My EKG shows I'm borderline. If my daughter was to have kids, what are the chances of her passing this condition down to her children?
That is 50%. So if she's a carrier, the chance that she passes the relevant condition to one of her children, and it doesn't matter whether this is a female or a male, is 50%. That is a genetic transferring the genetic condition. Whether he or she will have the condition on her EKG is lower than the 50% mentioned, because not everyone with the genetic condition does have the condition on the EKG.
And
Thank you.
There, Arthur, that one of the important things, and I think it's often confused, is just because mom's EKG is borderline, that has no relevance or bearing on whether a positive baby's EKG could be even less impressive or could be dramatically more impressive.
That cannot be predicted. So that's true. Yeah.
Great. Dr. Ackerman, I have a few questions here about the COVID vaccine for patients with SADS conditions. So the first is regarding the COVID vaccine for 5 to 11-year-olds. Would a child, say 3 or 4, who is considered medically vulnerable due to long QT syndrome be eligible to get the vaccine now rather than wait until spring when the under vaccine might be available for under 5? In Israel, for example, they're allowing younger kids to be vaccinated if they have a serious medical condition. So I think the question is, are SADS patients a vulnerable population, and should they be getting the vaccine earlier than it's available for that age group?
Yeah, great question. And I think we at SADS have done our best for 18 months now to sort of hit the drum again and again and again to encourage and remind our SADS family that their condition is not an exception condition to policy, meaning it's not a vulnerable condition that would warrant anybody going to the front of the line. So we have been very pleased, and Arthur can comment on it, but there's just been zero signal of an increase in long QT triggered, CPVT triggered, HCM triggered cardiac events in the setting of concomitant SARS-CoV-2 infection. So COVID-19 has not served as an agitator to these SADS conditions, for which it would make you more likely to need to go to the front of the line. And on the flip side, those of our patients who have a SADS condition, there's nothing about that SADS condition that's making them have a more severe SARS-CoV-2 COVID-19 infection. So they pleasantly get to wait their turn, because there's nothing about their condition that would make us think that we need to get them vaccinated more urgently than anybody else. And I think that's been some good news here.
Yeah, we do, if I may add, we do the same here in the Netherlands. The only exception we tend to make is for individuals with a Brugada syndrome based on a sodium channel variant. And that is because these individuals are at higher risk during fever, since an infection with the SARS-CoV-2 usually associates with fever. That is, I think, a good reason to be vaccinated earlier than the others. And around
that's a challenging one, isn't it, though, Arthur? Because, you know, the COVID-19 vaccine itself, especially after the second dose, some pretty impressive fevers can occur at times.
You interrupt me too early, because I was about to say that we advise them to have the vaccination associated with acetaminophen intake or paracetamol intake around the vaccination itself to prevent arthritis.
I think what's also what I'd add, Bryn, is we've been actually pleasantly surprised, I would say, that there hasn't been a signal, because you can think of each of these SADS conditions. We and others have put some pretty good in vitro evidence together to suggest that the virus can create an acquired prolonged QT picture. And so if the virus nudges the QT interval higher, which it does, then why aren't our long QT people having more episodes? And they're not, but I think it just makes it even more important, just like the fever drill with Brugada, that in the setting of COVID, they just cannot be put on QT prolonging medications because they've lost some margin. Our HCM patients, we showed that the ACE2 protein that the virus uses to hijack and steal entry into the heart cells is 5 times greater in the hypertrophic cardiomyopathy heart than in the normal heart. And so you would have thought that there's more ways for the virus to steal entry, and yet the HOCM heart is, they're not having more issues. In ARVC, which Brittney knows, and maybe from the ARVC center, you could comment, you know, if the virus infects the heart, or if the vaccine rarely causes a vaccine-associated myocarditis, that could be a nudger that revs up the ARVC. And yet we just haven't really seen this being a provocateur for these lesions. So we're glad we're not seeing it, because there was, for each of these conditions, the potential for a cellular mechanistic reason that if we would have seen a spike in events, we would have been able to have put together a nice cellular story.
Yeah, I would just add, Dr. Ackerman, to that. We were very concerned in the ARVC center about the myocarditis risk with COVID, because just on our floors in the wards, we've seen tons of COVID associated myocarditis in the general population. So we were very concerned about that in our ARVC population. And we've only seen really a couple truly severe COVID cases in ARVC patients. Luckily, for the large part, our patients are being careful. On the other hand, and I don't know if you want to comment on this on your patients as well, we have been very strongly encouraging when it's your turn that you should get vaccinated because of all of these hypothetical risks. And we have across the board, pediatrics or adult, there have been lots of questions in the ARVC population about the minuscule myocarditis incidents and maybe not getting the vaccine because of that. And we have not recommended that. We do strongly recommend the vaccine because of these hypothetical risks for all of our ARVC patients.
Great. There was one question about whether SADS patients with SADS conditions should get the booster shot. So along the same lines.
Yeah, I mean, I think Mayo Clinic view, CDC view is that yes. My own view is as the risk of the disease, COVID-19, gets less and less and less in certain age groups, for me, I need to see that the unwanted package of the vaccine itself needs to be close to zero. And so if I had a 5-year-old, would I be running to get my 5-year-old vaccinated? The honest answer is I would not. I personally would be waiting for some more miles to get under the tires to make sure that the risk benefit equation is as favorable as I want it to be. For my 25-year-old who was vaccine reluctant and remains so, and so he's only done one of the 2 doses so far, so he's a toe in the water guy. Do I want him vaccinated even though there's a measurable increase of COVID myocarditis from the vaccine in his age group and in his gender? Yes, I want him vaccinated. And so I don't like the one size fits all that, you know, you are age 13, therefore every 13-year-old run to get the vaccine. Now you're age 5, every 5-year-old run to get the vaccine because it's now age eligible. I do think there needs to be room, and I think Jennifer actually pointed this out in her talk, for individualization. And unfortunately, we're not really being permitted to individualize in the United States at all because we're currently under the cloud, if you will, of a federal mandate. And I don't know, Arthur, if in the Netherlands, has it been mandated to be vaccinated the way it has in the States, and whether you feel the same as, you know, I'm certainly not in a hurry for my granddaughter, who's not yet 2, for her to necessarily feel like my son needs to get my granddaughter vaccinated like instantaneously as soon as they declare it's open for the 2-year-olds. But I'm totally pro-vaccine. I just think there's room to think about every scenario and work through every scenario. I'll be quiet, let Arthur and Jennifer jump in from their physician perspectives.
I have nothing to add, Mike. I completely agree. I wouldn't, my granddaughter is not going to qualify for the vaccination as long as the government does not propose that. And that hasn't happened so far. So under 12, the kids are not vaccinated here. And above, I'm a strong believer in that it helps. So my 25-year-old, definitely. Nothing to add.
I think, Mike, you said it exactly right. For me, you know, it's an evolving risk benefit ratio. So there are a subset of patients that get very similar symptoms to COVID after the vaccine, because that's how the vaccine works. It, you know, amplifies the T cell mediated immune system. So I'm not going to tell people you're not going to perhaps unmask some underlying autoimmune disease, but your risk that you're taking is to believe that you are going to not be exposed to COVID when it's becoming endemic.
Mm-hmm.
So the question is, we are seeing a lot less COVID. I mean, I was just down in the emergency department now. We're seeing more endemic COVID, meaning they're not coming in symptomatic, but they're testing positive. This is what I think we're going to see going forward, as long as this new Delta strain kind of stays quiet for us. And so for me, the number needed to treat to prevent severe illness in the pediatric population, you know, I agree. I don't know if I'm personally there yet for my 11-year-old, given what's happening with COVID right now in the United States, because the risk of having something unmasked or uncovered, it's there. It's attenuated, but it's there. But your risk is getting severe COVID and becoming hospitalized, right? So I think it's an individual discussion. I think as an adult, because it's now here, I think that there's really no reason you should be getting you should be fully vaccinated. The pediatric population, I think we just need maybe a little bit more data. I think that you're not wrong in running out and getting your kids vaccinated. I think that that's just fine for you. But I also think that, one of my sons who has long QT, he actually, after his second booster, has what seems like long COVID. My husband had COVID, maybe he had it, he just tested negative, but it's been very debilitating for him. And so to see that to see that firsthand, it is hard. Did we make the right decision in getting him vaccinated at the time? Absolutely. I mean, this was very much a very real threat to him in the spring when we did this. But now seeing him out of school for a semester, I think that people need to know that this isn't an entirely benign thing to do. This isn't a placebo, right? And so I think as long as people are armed with the right information and look at the current climate, we're seeing flu now, okay? So I would tell everyone, go out and get your flu shot. We're already seeing flu A. That, in my mind, is going to be our threat coming into the winter.
Mhm.
Great answers. Sorry, go ahead, Dr. Ackerman, if you have more to add.
No, I just a great point.
This is a great question. Does anyone, do you know of any preliminary research that suggests certain types of diet may influence the QT interval?
I don't think we have any sound information on that. The only the only food that is so to say contraindicated for long QT patients is grapefruit. Grapefruit has been shown to prolong the QT interval. There is a study from Dr. Fiskin from Israel who actually studied this, but the amount of grapefruit that you need to consume on a daily basis in order to get a detrimental effect on your QT is huge. So I don't think in daily practice it is an issue, but I advise my long QT patients to be careful with grapefruit, but that is the only food that I contraindicate.
Yeah, I agree. I think from a diet standpoint, there's nothing about a carnivore diet or a Mediterranean diet or the Atkins diet that would be QT prolonging. I would say the only diet that I would give caution to are some of those rapid weight loss diets where you could have electrolyte disruptions. And so I think there just needs to be care given with those. But so I think most people are more or less talking about, Nutrisystem or Weight Watchers and all of those. Those are very QT safe. They're very electrolyte safe. I do encourage all of my patients to avoid Red Bull, Monster, highly caffeinated energy drinks. I think that's a QT danger setup. There's an unstated number of sudden deaths in that. It's going to be impossible to take down that market, if you will, because it's a multi-gazillion-dollar market. But these highly caffeinated energy drinks in the wrong host are potentially dangerous. And there's been some work published about its QT prolonging effect. So, but normal dieting, normal food groups, no danger. And both Arthur and I would love to see Sammy Viskin drink the amount of grapefruit juice needed.
Yeah, there was a question in the chat too about how much grapefruit is too much, and it sounds like it's a lot, amount that one could not consume in a single day. So
it becomes uncomfortable if you have to drink it.
Brittney, you might be able to answer this one. Someone in the chat said that they have ARVC type 5, which is TMEM43 gene, the Newfoundland curse. Do we know why or what makes this gene so aggressive?
Yeah, so TMEM43 or transmembrane 43 ARVC does look very different than desmosomal ARVC. So transmembrane 43, that protein is extra desmosomal. So it's not part of the protein complex of these bolts that hold your heart cells together. So there's a lot of work going on in Newfoundland really looking at it and why it's more severe, things like that. But I think the important kind of takeaway point is that it does look very different. And this is one of those kind of genotype phenotype correlations. So if you have the TMEM43 type of ARVC, if you are a young male, you are at very high risk of dangerous arrhythmias. And it is very what's called penetrant, meaning it's not this, you know, sometimes we see an ARVC it tracking through the family, you know, penetrance can be really low, you know, less than a quarter of people with the variant develop ARVC. It's very, very penetrant, does seem to have some correlation with exercise still, but that's still being worked out with the Newfoundland group, Kathy Hodgkins, etc. So yes, I think the bottom line is that it does look very different, and so should be treated with care differently.
Bryn, if I could follow up and ask Arthur to comment. I agree with Brittney that probably TM43 is going to be a more severe genotype, but the one cautionary note for our SADS condition families is almost every original gene at the very beginning got called a bad one. And then over passage of time, their particular substrate has gotten called less and less bad. And Arthur actually published a beautiful paper about this phenomenon that's been holding true for almost every genotype. And the only reason I want Arthur to comment is for families out there who might have one of the bad ones, I don't want you to necessarily be plotting the end of your life early, because it may not be as bad as advertised overall. And so, Arthur, could you?
Yeah, that's right. We had this paper on different diseases, but the TMEM43 variant in Newfoundland is a specific variant, which is always the same in every patient in Newfoundland. And the whole story may just hold for this specific variant. And as you know very well, there are also specific variants in LQT1 gene or in LQT3 gene in SCN5A that are more severe than others. And I do believe that this specific variant from Newfoundland is a very severe one.
Yeah.
But that doesn't mean that other variants in the same gene are equally severe, not at all.
Thank you. Jennifer,
I would
sorry, go ahead,
just
Brittney.
add that there's not a lot of evidence for any pathogenicity in other variants in TMEM overall. There's only a handful of them. So we see these variants of uncertain significance come up in TMEM all the time. And there's not a lot of evidence for most of them. But as Dr. Wilde mentioned, this specific Newfoundland variant, we do know a fair amount, you know, for many years.
Great, thank you. Jennifer, a question for you, I think. Would you have a recommendation for the type of a portable AED? I'm assuming the best type of a portable AED for a family to purchase.
Good question. I went to the AED Superstore and just looked at the ones that were the most affordable. I think that, you know, they all do the same thing. The question is, you know, are they affordable? How long is the battery life? And I would probably, and maybe, you know, you guys can disagree, not go for the refurbished ones personally. So in terms of brand, you know, I don't support one brand or the other, but the AED Superstore seemed to have all the brands, and it seemed to be just fine for me.
Great answer. Is there any link between CPVT and developmental delays in children? My 6-year-old son has always been behind the curve in every developmental milestone and has been considered to have a global delay. Based on conversations with other CPVT parents, it seems many of them have had similar experiences. And I think Dr. Wilde and Dr. Ackerman both could answer this question.
Yeah, I'm going to let Arthur take it because he's responsible for the paper that we did together that pointed this out.
Yeah, indeed, in a small subset of CPVT patients, there is evidence for developmental delay. The problem is it has not been studied systematically in all CPVT patients. It does, at least not as far as I know. But in a paper that we had with many centers around the world, we identified about 30 patients with CPVT and developmental delay. And actually the variants, there was some functional data on the variants involved. And these variants seems to be more severely affecting the calcium homeostasis in these cells. So the variants that are more seriously damaging or affecting the calcium homeostasis may also lead to developmental delay. And it's known that these receptors are also active in the brain, so the connection is easily made.
Yeah, and I think we're going to learn this better in time. I would want to make sure the CPVT families don't go looking for developmental delays that aren't there. So in other words, we have a lot of CPVT kids and families who are neurologic superstars and are functioning at high IQ. So if it's not there, you don't have to think it's the boogeyman around the corner where it's going to come out and rear its head. On the other hand, the signal that Arthur and we published was a 10% signal. And that's with us as cardiologists doing the neurologic phenotyping, which I must confess, we don't do it very well. And so I think in time and now many of the CPVT centers like Arthur's and ours, we're involving the neurologists and the developmental specialists when the parents bring this up, so that we're not just saying, well, yeah, CPVT and learning disabilities will sometimes coexist, but instead starting to say, maybe some of the learning disability is in fact stemming from the CPVT ryanodine receptor mutation itself. And that actually has some implications for helping the families get assistances in the United States, for example, with support mechanisms and things. If it's disease contributed learning disability versus, oh, by the way, learning disability, then that may enable and empower the families to get access to some resources. So, but again, most don't have it. So I don't want families with CPVT thinking that their A grade student is going to turn around and start having C's and D's, or for that teenager to blame the C's and D's on their CPVT.
Along the lines of developmental and other education concerns, do you do extra monitoring or take other precautions when starting a long QT child on ADHD meds? Do you have a preference of a stimulant or non-stimulant or even additional beta blocker for those children?
Yeah, I think this is a really important one. And I don't know if it was relevant for Jennifer and her kids. I can't remember. And Arthur, but I think this has been one area that we have done collectively far more damage to long QT families, is this notion of depriving them of meaningful ADD, ADHD therapies because those drugs have found their way on the QT drug hit list. So they're on credible meds. As we all know, we encourage our patients to avoid those medications that are on that list whenever possible. But that doesn't mean that that list of medicines is an absolute blacklist. It is a let's think carefully list. And we have a very sizable experience of long QT patients with concomitant ADD, and there is no connection there in terms of cause, because it's about 7 to 10% of my long QT kids have ADD. 7 to 10% of the globe has ADD. So it's not as if there's a contribution to ADD from the disease, which is different than what Arthur and I were just saying about the ryanodine receptor. But we have taken an approach that our families with ADHD, where the team and the have exhausted their non-pharmacologic strategies, behavioral therapies, et cetera, and their physician would have started an ADD stimulant long time ago if it weren't for the label long QT, that we have to stop depriving our families of having their ADD well addressed pharmacologically. I have zero fear of these stimulant medications in the well-diagnosed, well-treated patient. It doesn't matter which one. I don't have a favorite. So Ritalin, Adderall, Vyvanse, Strattera, doesn't matter the name. It's whichever one you and your development specialist are using for the goal of therapeutic efficacy of that substrate. And before Jennifer talks for what she's observed, Arthur, what is the status of this, like in the Netherlands? Do you have ADHD in the Netherlands the way we do in the United States, or what's going on there?
Yeah, we are also one of the Western developing countries. We are in the same group as you are, and the ADD issue is very similar to what it is in the United States. And I completely agree with you. And I think it's important to add that the patients, when they are beta blocker, are certainly safe. If they are not on beta blocker, it may be different. But well-treated patients, as you emphasized, no problem at all.
What about the anti-anxiety medications, the SSRIs for the long QT type 2? And that is well treated. What are your thoughts on those? Similar?
Same. That's a large swath. I mean, when we think of the state of mental health, which wasn't great globally before the pandemic, certainly is no better now during the pandemic. And we've seen a lot of people that have used up their reserve and their margin. And I personally think that any of my patients with any of their diseases who have anxiety, depression, that has exhausted cognitive behavioral therapies and so forth, where if the doctor, I don't want the doctor to choose an inferior anxiety medicine just because they think it's QT friendlier. So when they're starting to put our long QT patients first on Wellbutrin, for example, because it appears to be QT better, when it's nowhere close to being as anxiety, depression efficacious, I don't like that. I want them to go for treating that issue as best they can, and then leave it up to Arthur and I to make sure we're satisfied with how well their substrate is treated. And so I think we have caused this fear of treating long QT patients with drugs that are on the hit list when they really would benefit from those drugs. I think we've missed the mark, which is very different than the deaths that have occurred when somebody just willy-nilly put a long QT patient on levofloxacin for their hospital pneumonia without saying, wait a second, maybe I could just pick a different antibiotic. And I think those all got lumped together as kind of the same category of drug on that list, can't take that drug. And I think, again, things need to get tailored.
But you need sometimes an extra EKG when you start a patient. That is for sure. Maybe, and then if the therapy is upscaled, you might need another extra EKG. That is important, I believe. And
I think that whole thing, Arthur, is where we are very soon. I would say we're now months away from FDA clearance of having smartphone-enabled QTC monitoring occur with the gadgets that are out there. And one gadget is under FDA review. And I've used that already, even without it being approved or with the QT monitor turned on, where I do just that. I have them send me the PDF of their at-home acquisition when they've been sick or when a new medicine's been started. And I think that's going to help facilitate the safe use of those medicines.
Yeah, it becomes a lot easier, yeah.
Great, Brittney, I think I have a question for you. Any updates, info on ARVC pre-implantation genetic testing IVF for couples with ARVC wanting to start a family?
Yeah, that is a little bit of a loaded question. So it's complicated. So absolutely, it's I mean, the update is it's available. It's been available. You can do it if you want to. The complicated part of that, and luckily, then one of the only benefits of the pandemic has been is that I've been doing so much telemedicine, and it really frees me up to be able to have check-in visits with patients when they don't have to drag their bones to Baltimore, Maryland. And I've had a lot of kind of preconception discussions with patients about this, is that there's a lot of kind of pros and cons, and really think about what the risks are, and what you're buying with that. You know, in the United States, it's an incredibly expensive journey, and insurance coverage varies. And so, you know, often my preconception discussions with patients when they're thinking about embarking on that process are, you know, 90+ minutes, you know, discussing all of that. So I would say the update is, yeah, lots of people have done it, but I would caution you to really think through why you're doing it, what you're trying to avoid, and what the risks are.
Great. I have another great question. I think Dr. Ackerman, it goes along with your talk from earlier. Have similar AHA-ACC scientific statements expanded from "let me play" to "let me work" by passing pre-employment health screening for occupations like bus drivers, police, pilots, or military, as well as not being medically discharged from jobs based on stringent guidelines? So fantastic question.
Yeah, we're working on it. We have a paper in motion on patients in those high-risk professions, vocations, who have sudden death predisposing heart conditions. And it's going to be slow. So for example, we are really, really close to getting a pilot, a commercial pilot, reinstated into the cockpit with a genetic heart condition. That's a very different success story than getting a new person who wants to become a pilot and has to go through the journey of a solo cockpit, and go through being a flight instructor. So when you have a redundant cockpit at the commercial license, and that's when you've been discovered, very different opportunity scenario for success than that 18-year-old who wants to become an aviator. Almost for sure not. We have examples in the military where they're already an elite Delta Force Green Beret type person, and then their QT gets discovered. There's not a lot of desire to lose that multi-billion-dollar trained individual. Whereas on the front end, as long as the line is filled with people who want to serve, they will not want anybody who has any medical history. So it's going to take a while. We spend an enormous amount of energy to get our kids who want to serve in the military, who have these in the military. Our success rate is less than our athletes, but the success rate is no longer zero. So it's lagging behind our success rate with the athletes by about 5 to 10 years, but it's no longer been, you know, why keep trying? The answer is always going to be no. And so now I have long QT patients who are West Point grads, and the West Point knows that they have long QT. So it's no longer as, you know, terrible as what it was, but it's going to be very nuanced. I mean, you got to think of it, you know, I have several people serving as police officers, sheriff department, so forth. I would just say it's a very individualized, takes far more effort than it does with the athletes, with a far lower success rate currently, but we keep challenging the status quo. And Arthur, I'm curious, do you have a similar issue with, you know, professional vocation of at-risk, you know, skyscraper patients and things where falling or losing consciousness is not a great thing? And
maybe a little bit less strict as in the United States, but and I have the same experience that it has become more liberal, more easy in the last years compared to 10, 20 years ago. But you really need to invest time in convincing the doctors at the other side, at the airline company or wherever they are, to convince that these patients are low risk. I actually did some educational sessions for these physicians to help them understand what the development in our field is. and that may help in their ideas about all this.
I know we've had patients that have had, treated and cured Wolff Parkinson White, so status was ablation, and they're still not the pilot. They were applying to be in the military or be a pilot. They weren't cleared, so that's a very curable disease. So I think we have some more work to do, and it sounds like you both are very involved in that work. So that's wonderful. By the way, Alice and Marcia have given us permission to go until 3 o'clock since we have such great questions from the audience. So we'll keep going another 10 minutes here. Jennifer, I have a great questions for you from a community engagement standpoint. If families are interested in participating in a study, how can we do so or get more information?
Good question. I guess it depends on, what studies are available. There's always the NIH website that recruits for various studies. You can ask your, typically SADS will vet the investigators, whether it's, commercial or, academic, and try and recruit, because as you can imagine, we are a very valuable bunch, right? Having access to patients with a rare disease is a luxury for investigators. So if patients and families are indeed interested to be involved in studies, I'm sure that there are plenty of them. There are a lot of registries, which would be probably the first place to start. And getting involved in these registries, that's longitudinal data, so that would be very helpful. And then there are usually subsets of these registries that would qualify for the various studies. I think that the best place to start is likely the SADS website, and you can go from there if patients are interested, which is a great thing. There are plenty of studies all the time.
I agree. I think you can also ask your healthcare provider about studies that they may know of. Just like Jennifer said, there's lots of registries that are going on. Dr. Ackerman, Dr. Wilde, participate obviously in research, and you can contact their offices as well to be part of research studies. And so I would add to ask your provider as well, that they may probably know about things that are out there. The next question I think can be for Dr. Wilde and Dr. Ackerman, as well as you, Jennifer. My daughter with CPVT is a cheerleader and doesn't want to stop, but during a competition, we know that it's normally forbidden to have, assuming your heart rate over 200 beats per minute for a short time. Can medication be increased for competitions and then back to normal afterwards?
Yeah, I tend to say that is a policy that you can use. You can always test your CPVT patients with an exercise test and do the exercise test to the same level as the exercise in real life is. You can follow that with a Holter monitoring as well. And I do that on a regular basis to certainly with individuals who suffer from side effects of these drugs, to elevate it only at the time points that are relevant for them. So if the exercise is planned on Saturday morning between 10 and 12, then you take your extra medication at 8 in the morning on Saturday. And then the rest of the week you use your regular baseline medications.
Thank you.
But I used to follow up with I do the follow up with an exercise test, or in specific conditions like this, and Holter monitoring would be a good way to follow what is going on during that particular exercise.
This next one's a little bit more philosophical. Do you think athletes with SADS condition should have their own category within Paralympics or para-athletics, or do you think they should compete with athletes without a SADS condition? Basically, this question is about the patients with the SADS condition can't train to the extent of other athletes in certain instances, so may not be very competitive with those groups. So should we have a second category in these types of athletics?
No. So I think that's crazy. I think if we have gotten to the point where our patients with SADS conditions can participate in sports, they should participate in their age bracket, their gender bracket. If they have, my long QT patients who have Down syndrome, well, yeah, then they're participating in the Paralympics as a Downs. But there shouldn't be another athletic category for those who are on beta blocker therapy, and therefore their engine might be throttled down a little bit more compared to the athlete not on beta blocker therapy. So no, my enthusiasm for that would be pretty much set at 0.
And you can imagine some of the sports you might have an advantage, right? Maybe golf or ping pong or.
Yeah, you know, that whatever is that skiing and shooting one where they have to shoot, you know, there is advantage. And like you point out, Jen, I have plenty of athletes who actually think that they are now a better athlete on beta blocker. Some of my pitchers in baseball, some of my quarterbacks in football, where they just feel like the game has slowed down a bit for them, where they feel crisper. Now, of course, an athlete whose event is the 100-meter dash, they're not going to be as good of a 100-meter dasher sprinter on beta blocker. And that's
Mike, in the sports where shooting is involved, the beta blocker is in the list of forbidden drugs. So
right.
That's not going to work.
Right.
Yeah.
Great discussion. Are there situations where removal without replacement of a pacemaker ICD would be considered? And I think that's kind of a group question here.
Yeah, I'll start because we published probably the most about removal of diagnosis and removal of devices. So we've done both. So we've removed the diagnosis of long QT in over 1,000 patients. We've removed defibrillators in those people who didn't even have disease. But also, if you look at those with the diagnosis, where the diagnosis is correct, my own view is I and Arthur should not feel beholden to what the previous treatment strategies were invoked. And so if I agree with it, if I think they need it, we'll press on with it. But if we get to a place where we never would have put a defibrillator in the first place, I don't feel like I have to just continue that historical treatment decision forever just because somebody else made it. Now, if that decision is resulting in a flawlessly smooth journey with their ICD, then there's very little momentum to reverse course because they now have a life insurance package installed. On the other hand, if they've had racked up one side effect complication after the other, then they see us and Arthur and I want to put it in the first place, we're going to start thinking about how do we reverse course and explant the system.
So that's, going on to my talk on choose your provider wisely out of the gates. It is very hard to reverse a plan that involves taking leads out of your heart once they've been there for quite some time. Not impossible, but not ideal. It's better to get on the right course and get the right treatment from the beginning.
Great point, Jennifer. I'm going to ask one more question since we're getting close to the end of the hour. Again, I think this is for the panel altogether. I know that there's a list of medications to avoid for long QT syndrome, but there isn't one for CPVT. Sorry, just skipped ahead here. Basically, the question is, what drug should we avoid? Are there drugs that we should avoid or they should avoid for CPVT patients? Stimulants, things like that.
Monster.
Sorry, go ahead.
No.
I think the only
Monster
one
is what I think she said.
I think the only one is epinephrine. That is the most important one. And that is the point is that is also in use when you are in a situation of resuscitation, and then it becomes an issue where epinephrine is used. But we have had examples that epinephrine worsens it, and there has been a publication from John Skinner from New Zealand who clearly shows that epinephrine is really the drug to be avoided in CPVT, and for me that is the only one.
We also have to we have to remind everyone there is a Brugada drug list as well. So long QT and Brugada both have drug lists. Any final thoughts from anyone? I know that there's other questions that are still out there. We had a great lineup of questions. And I think we could probably ask them all day, but we'll leave it at that. And if anyone has any last thoughts, I think it's been an amazing conference and I'm very happy and honored to be part of it, but any other last minute thoughts from our panelists?
not from my side.
All right, great.
I would just add my thank you. I want to thank Dr. White and Dr. Wilde, Dr. Webster and Brittney for doing this, Bryn for you hosting this. And everybody have a great afternoon from my standpoint. And it looks like I get to be back with you tomorrow for a fireside chat, I guess, without the fire. I hope everybody has a great afternoon. Thanks, Arthur. Thanks, Jennifer.
Thanks,
Bye.
guys.
Thank you all. Great questions, great responses. Thanks.